So good morning and just about to be good afternoon, everyone. I will be talking on Bring Them Back, how to elevate abandonment in retinoblastoma. So this is something that I am putting across again and again to everyone because this is a task we had to face during the time of COVID, and we realized that we can actually make it a pattern all throughout and not just because of COVID. So, of course, we saw major abandonment in all diseases, not just retinoblastoma, because of the global pandemic that we saw. COVID-19 affected medical fraternity majorly, specifically due to the travel restrictions worldwide. And everybody was affected, and an important subset happens to be children, because children need to be brought to the hospital. They cannot come on their own. And the subset in that was the children with pediatric, basically patients with pediatric cancer, and retinoblastoma is where I'm looking at because of worldwide lockdown, COVID-19 pandemic, national and international travel restrictions. We saw loss to follow-up in retinoblastoma. And before I elaborate on this, I'll tell you that retinoblastoma loss to follow-up is very common, specifically because of the psychosocial aspects and the lack of awareness about retinoblastoma. Even if you tell a common man, they'll be quite amazed that there can be a cancer in the eye. So I will be focusing on the COVID-19 loss to follow-up that we saw, but it is pretty much applicable in all for us in a daily practice. So it's important for us to know that who are the defaulters, what is the tumor activity. We must triage. When a patient comes back to us after loss to follow-up, triaging is extremely important. We come with these painful pictures and images that you can see. This is a patient with orbital retinoblastoma. How to arrange for travel is a task. Can they be seen nearby? So many of the patients, they want to be seen locally. They don't want to travel all the way to the subspecialty center. And they're right, because they would like to be treated in the city that they live in. But unfortunately, we are not able to establish the same subspecialty all over India. So management protocols on returning will be different. So there are guidelines which have been established by the doyens for group A, B, C, D, E with risk factors, and even orbital retinoblastoma, that is advanced retinoblastoma. But what are the protocols when they return? Because now it has worsened up. It's not the same grouping ever. And what are the funding and government logistics? And of course, as I said, the psychosocial counseling and awareness is quite important. So this is a study that we did to observe 326 children, 476 eyes were affected. Our study we carried out from March 2020, that is the first loss to follow-up that started, and till June 2022, that means it was pretty much ongoing, and we have data which is updated till date. And we realized that the cases are basically emergent. That means they need to be dealt with within 48 hours, urgent within a week or so, semi-urgent is within a month, and then there are cases which can be left on follow-up normally as well. And we followed the quad triage method for these patients. So as you can see, these are the pointers that we have to keep in mind while bringing them back. It was quite a challenge. So this 326 number, it constitutes 77% of the children being treated, and this is not the active treatment. These are all the active cases that we saw. The median age was 57 months, and a delay that we saw was 8 to 80 weeks. So you can see over here, 8 weeks is just like a very nominal, like 2 months only. But in retinoblastoma, 2 months only is a very big thing. Like 2 weeks itself is a very big number. And over here you can see only 6% of the cases are local cases. So we see all the cases who are from the tertiary, because it's a referral center, we see all the patients who are referred to us from elsewhere. And socioeconomic scale kind of really does not matter. You can see that many of the cases are in upper middle class. We even have low class, upper class, everywhere. So it's irrespective of socioeconomic status that retinoblastoma hits the society. So we had to do documentation and maintaining the record. This is the best way of bringing them back. We have an internet Excel sheet as well. We call them the defaulter list. As you can see over here, we have a form that July 2020, the patient had defaulted. That means they were supposed to come in July 2020, Again, we kept calling them on a weekly basis. Soon we increased the calling because, if at all the patients are not responding, we kind of become like a hurdle for them every day. It's like, they're already dealing with cancer. We cannot just keep calling them. And then the patient eventually came back in April 2021. You see the gap there is quite significant. The means of communication, we call them up, we send them emails, we send them postal letters, but we have also seen no response in 16% of the patients during COVID pandemic. However, without the pandemic, our defaulter list successfully and proudly I can say is 1 to 5% maximum. We get all the patients back. The reasons were mostly travel restriction or family restrictions. We had to take care of real-time tracking because of the international and national updates. And the risk of analysis, as you can see over here, only 3% are urgent and 1% is emergent. So it's not an only number. It's a very, very big number because these cases need to be seen. Otherwise, we are looking at life risk. So we saw cases which were like opposite of what we hope. So the patients that we had left off with, like over here in group B, you can see the tumor is responding well. They came back after 7 months, the tumor is more florid. You can see the activity has increased. Same with group C, group D. You can see it's quite bad in the D and E groups. So these patients eventually have to be dealt with enucleation, which is quite unfortunate. So here you can see that many of the patients who defaulted were advanced retinoblastoma, group D and E. So on the last visit, many of them were active. As you can see, D and E, and however, this is the number that was regressed and this is the number that was enophthalmic. So we have to see for every single aspect. We have to establish high-level communication with the parents. You have to understand the reason for loss to follow-up and provide the solutions. It's very tailored management. We have to look at every single child and family individually, provide psychosocial support and reasoning to the parent. You can have, random communications that, the family is not agreeing. But it's actually the parents who come over here who understand the disease. The rest of the family is sitting at home and just sitting and giving statements to them that I should not be removed. Especially for girl child. They're really, off girl child treatment, and I'm quite disappointed with the same. Rescheduling the cases as per triage protocols is quite difficult as well. We had to issue travel letters, regularly we have meetings. Every single week we have defaulter list assessment, in fact on a daily basis. And we have Dr. Subhav here, he's also dealing with it on a daily basis. We keep a proper track on the patients. We try to refer to local ophthalmologists and coordinate with them. And in COVID time also we saw that focal treatment was provided for so many of the cases along with chemotherapy as well. So chemotherapy also we tried to arrange. And this is a patient who was basically on a regressed side, was in Dubai, and the patient was monitored regularly, very affluent family. They did indirect ophthalmoscopy by the ophthalmologist, but this was a peripheral tumor. They did not have the facility of examination under anesthesia, and this peripheral tumor was happily growing in the corner. So this was missed due to COVID pandemic. So we have to indent carefully, we have to examine the child. So when the patients came back, of course, we had to do optimal COVID testing of staff in hospital as well. And as I said, tailored entry management are something that we are looking at. So the generous contributions from the NGOs, it was very helpful, and I must say that for bringing the children back, it is quite important because financial support is very much mandatory and one of the reasons why these children go defaulting. And regular counseling of the constant defaulters is mandatory. As you can see over here, in a delay of 7 months, the children develop ACCs, and that is when we are looking at anterior chamber invasion or orbital retinoblastoma. Unfortunately, these children don't survive. So if this was 326 patients that we had in February 2020, we had 0 patients in May 2020, and it went to 63% in June 2021 and 81% in June 2022. That's a slow but very successful recovery. I do not call these numbers small. And with the local ophthalmologists also, we were able to recruit 21% cases. So these are the delays that we have seen, have been very painful, unfortunate. We have been able to, however, achieve 47% vision salvage, and I will not call this a small number. Eye salvage in 92%, and unfortunate 3% succumbed due to intracranial extension and metastasis. So to conclude, it is quite a medical emergency and it affects developing nations as well. So bringing them back is not just during COVID pandemic, it's on an every single day basis. And telementoring can aid in reaching out to the patients. And despite of tumor recurrence, you can manage these patients, never to give up on them. And even though 11 children succumbed to metastasis, we are happy to save 97% with a tailored management strategy leading to optimal recovery. So defer no time, because delays have dangerous ends. It's best to bring them back with patience and time as our powerful warriors. Thank you so much.
Thank you, Dr. Rolika. That was a wonderful presentation and so well documented. And you've gone into the details of the delays and what happened. So there's virtually no aspect of life or healthcare which COVID-19 did not disrupt. And here the disruption obviously led to unfortunate deaths and things like that. So now are things back to normal?
So they are back to normal, but as I would say that it's not just during COVID pandemic that we need to bring these children back. It's on a daily basis.
Right.
Even if COVID-19 has gone, the defaulter list will not go unless the medical, unless the oncologist, our team tries a level best to elevate this number. So we have to take care of it on a daily basis.
And during the pandemic, ophthalmic literature exists which suggests that more peripheral centers, closer access to the care also led to better follow-up, for example, in glaucoma care or other care.
Right.
So, I mean, there is no solution other than having more oncology centers spread all over the country and more oncologists, ocular oncologists.
Right, sir. And as I had mentioned earlier also, there was a very beautiful article written by Dr. Manjan Davida here on quad triaging. So she has made protocols for all sections of all the orbital diseases that we are looking at, and it was very difficult. That's why she's made sure that it is quad triaging that we follow. We have to triage as per the child is presenting. It's very much tailored management that has been advocated.
Thank you, everyone. Thank you, Dr. Rolika.